The beginning of the concept map, and I want to show you, before it gets too complicated, how to read it. Okay? So the God that we are serving throughout this entire set of notes is blood flow, right? Because the overriding function of the cardiovascular system is to do what? Ensure adequate blood flow to capillary beds, yes? And what we said last time was that blood flow was an interaction between pressure and resistance. Isn't that what we said? Okay, so when you are reading this, if it is green, that means this is a positive correlation, or as blood pressure increases, blood flow tends to increase, yes? And if it is red, it means that it's a negative correlation. As resistance increases, blood flow tends to decrease, correct? Okay, that's what we said last time. Okay, if it is any other color, it means that it could be either way, right? It's not a distinct negative or positive interaction. Does that make sense? So here's what we did last time, okay? We went over resistance, didn't we? We went over resistance. And resistance occurs primarily where? In the vessels, okay? And we said that there were basically some factors that added to resistance, and they were these, remember? The vessel diameter was a biggie. The viscosity of the blood and the vessel length. We didn't really talk very much about vessel elasticity, but we'll get to that a little bit later. Okay, is that all right? So if any of those increases, what it will do is decrease blood flow, correct? Okay, go ahead.
Green is direct correlation, red is indirect?
Yes. So if this one increases, that one increases. If this one increases, that one decreases. Does that make sense? Okay. Any other color, and then you can't predict it without knowing a little bit more. Okay. So, and then what we were starting on yesterday, guys, was one of the ways to generate pressure is with cardiac output. So remind me, and Charles knew this last time. If you were talking about pressure, there are 3 ways you can manipulate blood pressure. They are heart, that's here. Yes. Vessels, that's here. And fluid, that's here. Do you see that they are all connected to blood pressure? Heart, that's the pump. Vessels, fluid. Yeah, got it? Okay, now, what we started doing last time was we were talking about cardiac output, and cardiac output was the interaction between 2 factors. What are they? Heart rate and stroke volume, yes? And what we were doing last time is talking about stroke volume, okay? So, you with me? Stroke volume was what? Explain to me what stroke volume is.
I'm struggling with that. I don't understand.
How much blood leaves the heart? What? Per beat. Squish, how much squirts out? Me, 1/4 cup. Lance Armstrong, 3/4 of a cup. At rest. Does that make sense?
How much blood leaves the heart?
Per squirt. Ventricular contraction, if you want to say it specifically. Okay, are you guys with me? Okay, so we are going to look at the other factors related to stroke volume, but we talked about one of them last time, and you need to be able to remember that one. One of the factors that decreases stroke volume is called afterload. Somebody explain afterload to me.
Is the pressure against?
The pressure against which, right? The pressure in the arteries that the heart is pushing against, yes? As afterload increases, what happens to stroke volume? It decreases. Do you see that that's red? Yes.
That's saying it's it.
Yes. That says as afterload increases, stroke volume decreases. That's the relationship. Does that make sense to you? Okay. Yeah, it's an inverse correlation. Yes? Got it? Okay. So now what we have to do is there are 2 other factors that determine stroke volume. Yes? Okay. Today, you have to ask questions when you get confused. Don't try to do this on your own, and don't just sit there thinking that you're the only person who has that question. Okay? Because you are not. Okay, and hey, just let's just get a little stress out of the way, because do you remember in anatomy when people were like trying to teach you all the muscle actions, and the first time you heard it, you're like literally like, there is no way in hell I will ever learn this, but then you did. That's what's going to happen today. You'll be like, there's no way in hell I'm ever going to learn this, and then you will. Okay, but you're going to need some time with it. Okay, so ask questions. You ready? This part you need to pay attention to, and you need to not talk while I'm talking. Okay, ready? All right, so the next thing that is going to determine stroke volume is right here in your notes. So the other thing that affects stroke volume is called EDV, and listen to it as I break it down. It's end diastolic volume, but specifically in my head it's EDVV, because it's really end diastolic ventricular volume. Okay, so stick with me. What's systole? Contraction or relaxation? Contraction. What's diastole? Relaxation. Yes? Okay, so we're concentrating on the ventricles. You with me? Okay. You guys tell me, when are the ventricles going to be the most full? The end of diastole. Do you see that? Okay. When would the ventricles be most full? During contraction? No. At the end of contraction? No. At the beginning of relaxation? No. At the end of relaxation, right before the next contraction. So before we go any further with breaking down end diastolic ventricular volume, can you see for me that what is in your ventricles right before you contract will directly impact your stroke volume, will it not? Yes, of course, it's logical, right? And a positive correlation or a negative correlation? Positive correlation, yes? Okay, you got that? So what is in your ventricles right before you contract will directly impact how much is squirted out, yes? So it's not out of the realm of possibility. You just have to know what EDV has to do with, okay? So now we have to break out EDV a little bit and see what actually causes EDV to occur. And there are basically two things. This is the one that we're going to talk about first. The first one, and this was the one that people confuse, so don't be surprised if you are confused. I'll try to make it make sense. So stroke volume is affected dramatically by EDV, end diastolic ventricular volume, the volume of the ventricles just before contraction at the end of diastole. Yes? Okay. Tell me and fill it in. Increased EDV tends to do what to stroke volume? Increased stroke volume. Everybody got it so far? Okay. Now let's talk about one of the factors that impacts EDV. One of the factors that impacts EDV is that your ventricles can be full, or because they are not a rigid box, they can be fuller. Yes? So if you increase the amount in there, you're also increasing the pressure in the ventricles. Yes, you can get a ventricle full, but then you can put more blood in it because it's a stretchy bag, right? I mean, it has a limit, but you can get it full, but then you can get it fuller. So ventricular end diastolic pressure, this is the amount of tension in the cardiac muscle cells before ventricular contraction, or fuller, right? Is the ventricle full or is it fuller? Is there more pressure in the wall? If there's more pressure in the wall, that is called preload. Yeah, exactly. You're like loading it up and loading it up and loading it up. You're putting more in there, yes? So what? Loading a what?
Or a balloon.
A balloon. Yeah, you're filling it up and then you're filling it up fully, right? Okay, so this is called preload. So preload is happening in the heart. And as preload increases, predict for me, as preload increases and you get not just full but fuller, yes, what's going to happen to your EDV? Go up. And what's going to happen to your stroke volume? It's going to go up. Yes, got it? Okay, so preload, the amount of tension in the cardiac muscle cells before ventricular contraction. As preload increases, stroke volume increases. And then let's talk about how you impact preload. You ready? Okay, so how you impact preload also is relatively logical. You just have to sort of piece it together slowly and make it make sense. The way that you impact preload is, let's do this one first. Let's do atrial pressure first. Okay, what's in your ventricles came from your atria. If your atria contract really, really well, then it's going to impact your preload, which will impact your EDV. All a positive correlation, yes? If, like me, you have atrial fibrillation, I have atrial fibrillation. When I'm in an atrial fibrillation bout, you guys tell me how to predict what the hell is going to happen to my stroke volume and therefore my heart rate, okay? When you get into atrial fibrillation, my ventricles are still trying to do their thing, but my atria are tap dancing and not doing a damn thing, right? They're not helping anybody, right? So which of these factors is impacted first? No, first is atrial pressure. I'm not generating any atrial pressure. If I don't generate any atrial pressure, what happens to my preload? It drops. What happens to my EDV? It drops. What happens to my stroke volume? It drops. But if I still need the same level of cardiac output, I'm going to compensate when my stroke volume drops by doing what? Increasing my heart rate. And it gets really high and thready. That's what happens. Does that make sense? This thing is atrial fibrillation. It's atrial fibrillation that I have. Yeah? Does that make sense? Okay. So do you see this little relationship? Everybody good with that? Okay. This says what happens in your atria impacts how full your ventricles are. How full and pressured your ventricles are will impact the volume that you are going to squirt out. That's what's related there. Go ahead.
So do we have to say talk about the preload in that whole thing? So if atrial pressure drops, do we have to say then preload doesn't happen as well, which drops?
You need to know what preload is. Okay.
If we have to say if we have a question on it, would saying preload help us out, or
Probably.
Okay.
I don't know. I haven't written the questions yet. Okay. The last little thing that is going to impact this is that filling time matters. How much time you allow your ventricles to fill will matter. So does it make sense to you that your heart rate can get so fast that you can't have adequate filling time? Yeah? And if you have poor filling time, it will decrease your preload, decrease your EDV, and therefore your stroke volume, right? This means that there's a sweet spot, right, for how fast your heart rate can go, right? So here's the filling time prediction, guys. Filling time, it's dependent on heart rate, of course. As heart rate decreases, filling time and preload will both do what? Increase, yes. Yes. That makes sense? You have to decrease your heart rate a little bit to allow it to fill. Now, can you get too low? Hell yes, right? Can you get too high? Well, of course, right? But there's a sweet spot for both stroke volume and heart rate. Okay? All right. So it is a range. Yes, it's not a spot. It's a range. Yes? Okay, everybody good? Okay, so what you have just learned right here is another factor called EDV, end diastolic ventricular volume, that is a direct predictor of your stroke volume. And then you learned the things that actually add to EDV. Got it? Okay. The only one that people really confuse is preload. That's just how much pressure is in the ventricle before you contract. More pressure will give you a better end diastolic ventricular volume, right? Okay, all right. So the last thing that is going to impact EDV right here is going to be Starlings Law. And Starlings Law I totally think is cool. Starlings Law says that this is what is true about your heart. Your cardiac muscles, sarcomeres, contract better, have better cross-bridge cycling when they are stretched. So your heart, unlike a skeletal muscle, will actually contract better and have better access to cross-bridge cycling when it's stretched. Let me show you why. Okay, so here is cardiac muscle. Okay, so all I am doing here is getting the heart really full. EDV is going up, right? And do you see what will happen to the sarcomere when I get the heart really full? The sarcomere actually stretches a little bit, so you actually have more access to cross bridges and more access to cross bridge cycling, right? So it can actually contract better. What?
The A-band widens?
Well, no, the A-band stays in the same position, but what really happens is the H zone is widening. Yeah, the H zone is widening. That makes sense? Okay, so you have more access, right? So when it's stretched is actually when it squirts the best. Fill it up, it squirts better, is what it's saying, right? Does that make sense? An increase in EDV causes stroke volume to increase. This is not a nervous system stimulation. It's not hormonal. It's not paracrine. It's just mechanics, right? Stretch it, it actually contracts better because it has better access to cross-bridge cycling. Does that make sense? So basically the heart is really evolved to contract really well when it's full. That's what it does, okay? So let's look at the reasoning behind this and how it actually makes sense before we move on to the next thing. So this is called Starlings Law, and it says that more in will cause you to contract better to get more out. So do you know the term venous return? Venous return is just the blood that is returning to your atria through your venous system, okay? So venous return, let's just think about this for a second. Arterial flow is directly correlated to what the heart is doing, right? But venous return isn't directly correlated to what the heart is doing, right? It's pretty low pressure and it's primarily based on muscles and respiratory system, which we'll talk about in just a second. But basically, as venous return increases and you're getting more blood in, what happens is you stretch your heart to the optimal length and you get more blood out, right? And what this does is it prevents the overloading of the heart. It actually allows the output to match the input, right? Does that make sense? It's the output matching the input. Okay, so this prevents enlargement of the heart. Otherwise, if the blood was basically backing up there, then the heart would have to continue working really hard. But this says, as you get stretched, you actually snap back better. You actually contract better. Okay, so increased venous return, let's talk about how you would increase venous return because you've actually talked about this before, probably in anatomy. Venous return, instead of being directly related to what the heart is doing. It's actually directly related to what is doing. Yes, skeletal muscle contraction, right? Right? Skeletal muscle contraction around your veins. Most of your veins, not all of them, have one-way valves in them. If you are exercising, for instance, you are contracting your skeletal muscle and squishing on them, and the blood's coming back up, right? That makes sense? So increased venous return is due to what we call the skeletal muscle pump. And then who remembers what else causes venous return? Right, who remembers? Yeah, it's the respiratory system. Do you guys remember the respiratory pump? The respiratory pump helps with blood flow this way. And that is that, so the pretty much most vessels, most veins in the ventral body cavity don't have valves in them, even though some of them are really big and it's going backwards. They don't really need valves in them because what you have is, just think about the inferior vena cava because the rest of the veins work the same way. Inferior vena cava goes, of course, through the ventral body cavity and then through the diaphragm and up, right? Okay, so here's what happens every single time you inhale. Every single time you inhale, the diaphragm goes from being shaped like this, right, bell-shaped, to flat, right? And what happens to the pressure down here? Increases. What happens to the pressure up here? It decreases, yes? And what happens to the fluid? High pressure to low pressure, you squirt it up. Every single time you breathe, you squirt it up the vessels, so you don't need any valves in there, right? And so now let's think about what's happening when we're exercising again. Now, we've all known for ages that when you're exercising, your heart pumps more blood out into the arteries. But now let's talk about venous return when you're exercising. Your skeletal muscles are contracting to get it back, and you're breathing more frequently and more deeply, right? And the blood's coming back. Yeah, does that make sense? So that's the back end, venous return. So what is happening during venous return is Starling's Law, which says that the stretching will cause them to be at their optimal length, get them more full, and they're going to work better. That's what happens. That makes sense? So that's called Starling's Law. So what we just did was the Starling's Law is directly related to venous return. And venous return is primarily controlled by the skeletal muscle pump and the respiratory pump. What else does venous return aid? Well, it aids in atrial pressure, right? More blood you actually put in. That makes sense? Okay. So now what we have is we've said that we've got the whole damn story for stroke volume. Stroke volume is positively impacted by EDV, negatively impacted by afterload. We'll add one last little thing right here. You guys ready for the last little thing? And this one's relatively easy. Okay. Any questions? You all right? Okay. All right. So one thing I want to tell you is that exercise, of course, can you see that what exercise is going to do is increase your stroke volume pretty dramatically? Yeah? Repeated cardiovascular exercise will allow your stroke volume to increase really dramatically. And when your stroke volume increases really dramatically at rest, then what can happen to your heart rate? It can decrease at rest. So Lance Armstrong has a stroke volume of about 3/4 of a cup, and his heart rate is about 37 beats per minute at rest when he was in his prime, right? What do you think is better for you over a long period of time, a high resting heart rate or a low resting heart rate? Yeah, a low resting heart rate. You want to use it efficiently, but infrequently if you can. That makes sense? So that's so what he has done is basically done this kind of training that increases his stroke volume so his heart rate can go down. But what can happen is if you have a resting heart rate of around 72 beats per minute, I don't know what mine is, it's usually 70 to 72 beats per minute. If you have a resting heart rate of around that, you know that you still can go up to into the 200s, right? If you needed to, you totally could. So 70 to 200 is my cardiac reserve, but his is 37 to 200. That's his cardiac reserve. So he has a tremendous cardiac reserve, tremendous capacity for cardiac reserve. Is that okay? Okay. All right. So the last thing to cover on stroke volume is ventricular contractility. And when I'm telling you about ventricular contractility, here's what I want you to be thinking about. Compare and contrast ventricular contractility with Starling's Law, okay? I want you to listen for the differences because they're similar to one another, but they're different, okay? So Starling's Law is If you fill it up more full, it actually gets to optimum sarcomere length, and then it contracts better. Ventricular contractility will be for an entirely different reason. What ventricular contractility is hold EDV constant. Don't change the volume, but stimulate the wall of the ventricle with the sympathetic nervous system. And you may or may not have already learned, but the sympathetic nervous system doesn't just increase heart rate, it increases strength of contraction and therefore stroke volume because of the way that the sympathetic nervous system is hooked up. So let me show you the sympathetic nervous system hookup. So look here for just a second. So here's parasympathetic. We don't care about you right now. With sympathetic, you know it comes from the thoracic region. Notice it goes to the SA node and the AV node. That's going to be heart rate. We're not talking about that yet, but of course it does heart rate, and you've known that. But please note that it also goes to the wall of the ventricles, yes? So it impacts strength of contraction, yes? So what will happen is when the sympathetic nervous system stimulates the heart, it is actually going to increase stroke volume as well as heart rate. Does that make sense? Okay. Please note that the parasympathetic nervous system is not hooked up to the ventricle. Do you see that? Not hooked up to the ventricle. So now back to our idea and our question. Can anybody, in your words, tell me the big difference between Starlings Law and ventricular contractility? What is, go ahead.
Starlings Law deals with the atrium.
No, Starlings Law doesn't deal with the atrium. It deals with the ventricle. Go ahead.
So Starlings Law is about the sarcomeres in the muscle fibers,
Mm-hmm.
and ventricular contractility is directly hooked up to the myocardium, helping out with the strength.
Yes.
But then the Starlings Law is just makes it more efficient. Right?
Yeah, it makes it more efficient. Which one of these changes due to volume changes? Which one?
Starlings Law.
Starling's Law is volume change will cause greater contraction, and this one holds volume constant, but stimulates with the nervous system. Does that make sense? Okay.
So it does.
Do you see that this one doesn't have a damn thing to do with EDV? Do you see that? It doesn't have a damn thing to do with EDV. It bypasses EDV completely and goes straight to stroke volume. This one goes through EDV and then to stroke volume. Got it? Yeah, it's the volume, right? Starling's Law has to do with volume. Ventricular contractility does not have to do with volume. Ventricular contractility holds the volume constant. Okay? Got it? Okay, so the three factors, go ahead.
That was between Starlings and EDV.
No, Starlings and ventricular contractility. Yeah. Starlings and EDV are very closely related to one another. Okay? All right. So, ready? So, basically, one more time before we leave, stroke volume. There are three ways to manipulate stroke volume. The way that will decrease stroke volume is to increase what? Afterload, right? And there are two ways that will dependably increase stroke volume. One of them is to increase EDV, which is volume related, hence the V, yes? And the other way is to skip the volume altogether and directly stimulate the ventricle of the heart with ventricular contractility. Yes? Got it? Okay. Yes? I know two people have it. The rest of you are just staring at me. There's like nothing is happening. Okay. So, Amber, you ask a question today. Do it. Okay. All right. So now, of course, the next thing that we're going to do, since we've been talking about cardiac output, is heart rate. Yeah. Heart rate is not hard, guys, because you already know autonomic nervous system, and that is what primarily controls heart rate. Yes. The only thing that I really have to teach you that's different about autonomic nervous system today is that it's not always a tiger in the room that starts the sympathetic, and it's not always chilling out that starts the parasympathetic. There are other inputs that we use. Does it surprise you at all that you monitor your own blood pressure to figure out when to activate the sympathetic or the parasympathetic nervous system? Does that surprise you? No. Right? You don't even have to have a tiger in the room to activate the sympathetic. If your blood pressure was too low, you'd activate the sympathetic. Okay, got it? Does it surprise you at all that you also monitor the chemical content of your blood, like carbon dioxide, oxygen, and pH, to decide when to activate the sympathetic and the parasympathetic nervous system? Aren't those inputs that are logical? Right. Okay, so that's all we're going to do is we're going to put together those other reasons that you haven't learned yet about starting the sympathetic and parasympathetic nervous system, but it's still going to be autonomic nervous system. So the next thing that we are going to talk about is the factors that are impacting heart rate. So, of course, regulating heart rate is one of the effective mechanisms to regulate cardiac output, therefore pressure, therefore flow, right? And this is the God of the entire table, right? Flow. So we know stroke volume now, and now let's talk about heart rate. You ready? Okay. So heart rate. Do you remember, without looking, which part of the brain controls heart rate? Medulla oblongata. Good. So what we're going to have is the medulla oblongata is going to get to decide under what circumstances we will activate the sympathetic nervous system or activate the parasympathetic nervous system. It's all subconscious decisions, but it's still the decider. Yes? Okay, got it? Okay, so basically in the medulla oblongata, guys, here, there are a couple of little gray matter nuclei. You don't have to know their names. I'll tell you just so that you run into them later. The whole part of the medulla oblongata that controls heart also controls vessels, okay? Because think about this for a second. When you control the heart rate, are you affecting the entire system? That's systemic control. So think about this for just a second. If the medulla oblongata decides that it's time to turn up your heart rate, what is something consistent that it could do with your vessels? Constrict. Yes. Yes? If the medulla oblongata decides to turn down your heart rate with the parasympathetic nervous system, what is something consistent that it could do with your vessels? Dilate. Got it? Okay. So when the medulla activates, it's generally going to do both of them at the same time. It'll do heart and vessels because we're talking systemic. Yes? Got it? This is not local. You with me so far? Okay, so basically the little chunks of the medulla oblongata, the gray matter in there, they're called collectively, this isn't particularly important, so don't let the syllables confuse you. The medullary, because of medulla, cardiovascular, because heart and vessels, control center. Got it? That's the part of the medulla oblongata that's controlling heart rate. And specifically, there's a little chunk that's called the cardioacceleratory center that's hooked up to the sympathetic. Got it? And there's a little chunk called the cardioinhibitory center that's hooked up to the parasympathetic, right? And when you're going parasympathetic, instead of going directly out, you go down to the thoracic region and up, okay? All right, so part of the medullary cardiovascular control center is connected to the sympathetic nervous system. And you guys already know this, but let's just make sure that you can go through it. It sends action potentials to sympathetic neurons. We remember where they go from here, right? And the sympathetic neurons go up to the SA node, the AV node. That's how you control heart rate. But then we also just learned that they go to the myocardium to control stroke volume. Yes? But what do you know about them? You already know this stuff. You know that the type of the neurotransmitter that's going to be released from the sympathetic nervous system at the heart is what? Norepinephrine. The next question is the thing that you were just answering. What type of receptors are involved? Adrenergic, and they're actually beta-adrenergic, FYI. Administering epi clinically has the same effect, whether it's Pulp Fiction or me going into anaphylactic shock or somebody going into septic shock. What happens in that situation is you get massive vasodilation, right? Your blood pressure drops to damn near nothing. And then what do? They give you epi, yeah, which has what effect? What does it do to your heart? Increase. What does it do to your vessels? Constrict. What does it do to your blood pressure? Raises it. Yes. Got it? Okay. So whether epi is dumped into you from your adrenal medulla or shot into you with a syringe, it has the same effect. Got it? Okay. Now, the other part of the medullary cardiovascular control center is hooked up to the parasympathetic nervous system. Go ahead.
Why in an EpiPen does the epinephrine come out so fast and strong versus if you were just to do it like with the syringe, you have to push it that much?
I don't know. Anybody know why in an EpiPen it comes out so fast and strong? I've never actually used an EpiPen before.
I think they're just trying to deliver
As much as quick as possible. They want like to limit human error so that you actually get it all there. Yeah. Like get it all in there as quickly as possible because you're about to croak, and also maybe you wouldn't get it all in if you like passed out before you got the thing plunged in. I don't know. You are? I don't know. Don't I have an EMT in here who can tell me that?
That's just for safety, like keeping it there to make sure it
all gets out.
Get anywhere else.
Oh. Oh, okay. Oh, interesting. Okay.
Mine would be like instantaneous, like IV drug versus oral medication.
Okay, so
Explains that,
parasympathetic nervous system goes, do you guys remember what nerve the parasympathetic nervous system uses? Vagus nerve to the heart, yeah, which is cranial nerve number 10. Good job. Okay, vagus nerve. But please note that with the parasympathetic nervous system, SA node, AV node, no communication whatsoever with the ventricular myocardium. No direct impact on that at all. So it affects heart rate, but not stroke volume. Not directly. It has an indirect effect on stroke volume, but it's only indirect. Okay, so you guys already know this. Parasympathetic nervous system secretes acetylcholine, decreases heart rate. What type of receptors? Cholinergic. Good. So you already know this too. Generally, parasympathetic stimulation is dominating. So if you cut all the nerves off your heart rate will go up to 100 beats per minute or so. Okay, so now briefly, let's talk about hormonal control of heart rate. So hormonal control of heart rate. So we just talked about nervous system control of heart rate, which is exactly what you thought it was going to be, yeah? And hormonal control of heart rate, well, epi is a hormone, right? Okay, so that would be hormonal control of heart rate. So let's go back to our thing here and say, okay, how do you control the heart rate? You control the heart rate by controlling the rate of depolarization of the pacemaker cells, right? That's the SA node and the AV node. And you do that by sympathetic and parasympathetic innervation, or you could get it there by epinephrine as a hormone, right? Either way, what do sympathetic innervation or epi as a hormone do to the rate of depolarization? Increase it. That's why they're green. And what do they do to the heart rate? They increase it. What does parasympathetic innervation do to your heart rate? Decreases it. That's why it's red. Yes, got it? And it doesn't actually have any impact on hormonal release. It doesn't actually release a hormone with the parasympathetic nervous system. So adrenal medulla epinephrine. So epinephrine is secreted by the adrenal medulla during sympathetic activity, and it increases both heart rate and strength of contraction. Yes? And then thyroid hormone, T3 and T4, not super important for a regulatory hormone, but I just want to tell you that since your thyroid hormone increases metabolism of all tissues, it also increases the metabolism and therefore the heart rate. So the only reason that that's important is because if you have somebody who's hypothyroid, their heart rate's slightly lower. And if you have someone who's hyperthyroid, their heart rate's slightly higher. But we don't really use thyroid hormone as a regulatory mechanism for heart rate. Do you see what I mean? We use epi, yeah, but we don't use thyroid hormone. It does impact heart rate, but over long periods of time, right? Does that make sense? Okay, so other factors do influence heart rate. Temperature will make diffusion occur faster, and doesn't the pacemaker thing all start with calcium diffusion? It's just going to occur faster at higher temperatures, yeah? But, and slower at lower temperatures. But it's okay for your heart rate to be slower at lower temperatures because your metabolism also slows down at lower temperatures. Is that okay? Okay, now we know that your emotions can directly impact your heart rate, but it's actually not direct. Here's what happens. Limbic system, cerebral cortex, general craziness, hypothalamus, right? Actually tells your medulla oblongata there's a freaking tiger in the room when there's no tiger in the room, and your medulla oblongata goes, I got this. And what does it do to your heart? Increases your heart rate. It's like tigers, man. I'm pretty sure there's tigers in here, right? That's what happens every time you get anxiety. Okay, so, and then of course, the other factors influencing heart rate are all of the ions that are involved in cardiac muscle contraction. If those are abnormal, your heart's going to be abnormal as well. Potassium, sodium, calcium specifically. And then what does endurance training do for your heart rate? Well, what endurance training does for your heart rate is it dramatically increases your stroke volume by a couple of different things. When you do endurance training in your Lance Armstrong, you clean out your blood vessels, so what happens to your afterload? It decreases. And then you increase your strength of contraction with training, so what happens to your EDV? It increases, yes, and your stroke volume goes way up, so what happens to your heart rate? Goes way down, exactly. That's what endurance training does. That make sense? Okay, so just a little clinical connection before we move on, and then we'll talk about inputs for autonomic nervous system. So clinical connections. Congestive heart failure is an interesting one to talk about. It is also one that we have in several of the cadavers. If you've had anatomy, Have you seen some of the cadavers with ginormous hearts, just enormous? Okay, having a big heart is not so great, really, because it generally means that congestive heart failure has gone on. Let me explain congestive heart failure to you. Congestive heart failure has to do with the ventricles not being able to keep up with venous return. Venous return is relatively passive, right? It's not directly related to what your ventricles are doing. Do you understand? Okay, does it make sense to you that when I'm talking about the, especially systemic circulation, does it make sense to you if I call arteries front end and veins back end? Okay, all right. So here's what's going to happen with systemic circulation overall. So we are going to go from my left ventricle back to my right atrium, yes? Okay, now if something is wrong with my ventricular strength, if I've just had a heart attack, if I've got massive arteriosclerosis, right? Then what's going to happen is it's really going to affect the front end, but not so much the back end. You with me? And the back end is going to keep coming and keep coming and keep coming, and eventually you're going to get congestion, think traffic jam, yes? And the traffic jam is going to occur because the input keeps coming in, but the output can't keep up with it, yes? Okay, that is a really common complication of untreated hypertension, in which the afterload is too high and you can't battle against it, or you just have a heart attack, right? And your ventricles are too weak and they can't keep up. So what happens is the congestion builds up, and it builds up in the venous system, and it builds back up until it hits a capillary bed. So let's say first that your right ventricle is failing. Right ventricle is failing, okay? So if your right ventricle is too weak, let me show you a figure up a little bit. Okay, where are you? If your right ventricle is too weak, so this is two forms of congestive heart failure. So if your right ventricle is too weak, it's going to back up until it hits a porous capillary bed, and then it's going to leak out. So if your right ventricle is too weak, where is it going to leak out, that fluid? Because the pressure is so high in your venous system. Now, right ventricle, follow it back to a capillary bed. Where are the capillary beds? Where?
Interstitial fluid.
Yeah, it's going to leak into the interstitial fluid. Where? In the body. Yeah, all in extremities primarily. It's really hard to get the fluid back from your extremities anyway, and now you're building up pressure in your veins, and it actually pushes it out and it causes edema in your extremities. So you wake up with swollen hands and feet, and you didn't eat a bag of Doritos yesterday. You're just going to wake up with swollen hands and feet. Does that make sense? Okay, it's called peripheral edema. Go ahead.
Is that common with diabetes?
Yes, super duper common with diabetes. Diabetes trashes your cardiovascular system. It's really, really hard on your cardiovascular system, especially if it's not treated properly. Go ahead.
So they go hand in hand, diabetes
Diabetes very often causes cardiovascular abnormalities, which can lead to congestive heart
So
failure.
those are where the symptoms come from.
Yes, quite often. Not always. There's a million reasons that it could occur with diabetes. It also screws up your fluid composition, your ion composition. Okay, go ahead.
What is the reason for purple legs? Is that diabetic as well?
Swelling in the ankle. Well, first of all, the swelling occurs. Second, you've got really poor blood flow, and you can start actually breaking capillaries because of the high pressure down there as well. Okay, so now let's look at the other one, which is actually more common. Your left ventricle has a lot more work to do, right? It's got a lot more vessels to push against, a lot more resistance to push against, and it's a lot harder to get them through if it's really high pressure. So if you've got arteriosclerosis in your arteries, then your left ventricle is trying to push into them, right? So let's say we've got congestive heart failure and our left ventricle is too weak, yes? Now I want you to think about this. Follow blood to a capillary from the left ventricle. Follow it backwards. Traffic jam. Where does it leak out? Lungs. Yes, it leaks out in the lungs. And it causes fluid buildup in the lungs, pulmonary edema. It will cause shortness of breath. Eventually, it can cause pleural effusion, in which you leak fluid from the lungs into the pleural sac. Look at how much this would decrease your ability to inhale and exhale. Does that make sense? Have you ever wondered why heart abnormalities cause shortness of breath? This is one of the major reasons that heart abnormalities cause shortness of breath. So if your heart is too weak, it will back up into capillary beds, and the left ventricle backs up straight to the lungs. Does that make sense to you guys? Okay. All right, so that is congestive heart failure. Now, interestingly, this will reinforce what you've already learned. If you have way high pressure in the system leading to congestive heart failure and you need to treat it, you treat it the 3 ways that you treat all pressure in the body. How do you manage pressure in the body? Pump, fluid, vessels. How do you treat congestive heart failure? Digitalis treats the pump. It slows down your heart rate and makes each beat really strong but infrequent, right? Diuretics are going to treat the volume, right, and make you pee more. And vasodilators are going to treat the vessels. Yeah? Any combination of those. Does that make logical sense to you guys? Okay, cool. All right. So now, mechanisms of controlling blood pressure. And so what we're going to get now is what other than a tiger in the room can turn on the sympathetic nervous system? What other than exercise? What other than just chilling the hell out will turn on the parasympathetic nervous system, right? So there are other inputs. And you guys already said that you understand that you can, for instance, decide to turn it on, the parasympathetic nervous system on if your pressure is too high, right? So you can monitor pressure and you can monitor the chemical content. Right? Does that make sense to you guys? Okay, so what we are going to do is now we're going to talk about extrinsic control of blood pressure. So how do you control blood pressure? The ways in which you control blood pressure. So here we go. So where we are is we already said that we know that the sympathetic and the parasympathetic nervous system, which are part of the autonomic nervous system, are going to control the rate of depolarization, right? And therefore the heart rate. You got that, guys? Okay. Now let's look at ways other than tigers that turn on the autonomic nervous system, okay? And we are going to have what we call baroreceptors and chemoreceptors. What does baro imply to you? Pressure. Okay, so let's talk about the baroreceptors first. So how do you decide when to turn on the sympathetic versus parasympathetic nervous system? Okay, here we go. The truth is that you have baroreceptors a couple of different places. You have baroreceptors in your aortic arch, yeah? That are monitoring what? Arterial or venous blood pressure? Arterial blood pressure. And you've got, and this is arterial blood pressure to the whole damn systemic circulation, right? Because that's where the aorta goes. Yeah. And then you've also got baroreceptors in your carotid sinus, which is monitoring pressure to where? Brain. Okay. These two do the same thing, but one of them is way easier to piss off. Which one? This one, yes. This one is way easier to piss off. It's more finicky. It's also more susceptible to body position changes. Have you ever gotten up super fast and you get all lightheaded? You piss this one off long before you piss this one off, right? They do the same thing. Does that make sense? Okay. Okay. So they're called arterial baroreceptors. This one is the aortic arch, and this one is the carotid sinus. They do similar things. Okay. So let me show you how they work. Okay, what they are going to do, you predict before I show you the animation. If you detect high pressure in the aortic arch of the carotid sinus and you tell on it to the medulla oblongata, you're like, I'm telling with sensory information, then the medulla oblongata is going to respond to high pressure by turning on, choose, sympathetic or parasympathetic nervous system. No, you just detected high pressure here and here. Yeah. And you told the medulla oblongata, and the medulla oblongata is taking care of business by turning on the parasympathetic nervous system. Got it? Okay. All right. So let's see. Let's see that happen. You ready? Okay. So baroreceptor reflex control of blood pressure. Oops.
Stretches the carotid arteries and aorta, causing the baroreceptors to increase their basal rate of action potential generation.
Let's just acknowledge that that is not the carotid sinus. As an anatomy person, I'm like, that's the brachiocephalic artery. Okay, there you go.
Action potentials are conducted by the glossopharyngeal and vagus nerves to the cardioregulatory and vasomotor centers in the medulla oblongata.
You don't have to know the name of any of those nerves. It's basically just sensory information, high pressure to the medulla oblongata. And now let's see what happens, okay?
As a result of increased stimulation from the baroreceptors, the cardioregulatory center increases parasympathetic stimulation to the heart, which decreases the heart rate. So it increased parasympathetic. What's it going to do to the sympathetic? Decrease, yes. Okay, good. Also, as a result of the increased stimulation from the baroreceptors, The cardiovascular center decreases sympathetic stimulation to the heart, which decreases heart rate and stroke volume.
Yeah. Okay, before he tells us, you tell me. What can we do to the vessels that would be consistent? Vasodilation, yes? Okay, yeah. And so what you're going to have to do is vasodilate. And remember, vasodilation is just changing the sympathetic stimulation because you have no parasympathetic innervation of vessels, right? Do you guys remember that? Okay, he's going to tell you.
The vasomotor center decreases sympathetic stimulation to blood vessels, causing vasodilation. The vasodilation, along with the decreased heart rate and decreased stroke volume, bring the elevated blood pressure back toward normal. If the initial problem were a decrease in blood pressure, the activities and effects of the baroreceptors, cardiovascular center, and vasomotor center would be the opposite of what is illustrated.
So let's just do the opposite example to reinforce it. You ready? What if you get up super quickly and detect either place, but especially at the carotid sinus, you detect low pressure, yes? Then where are you going to send that sensory information? Medulla oblongata, and the medulla oblongata is going to respond to low pressure and these baroreceptors by activating which one? Sympathetic, which will do what to heart rate? Increase it. Does it have an impact on stroke volume? Yes. And what will happen to your vessels? Constrict. Got it? Got vasoconstriction? You got it? Okay. So that is the baroreceptor reflexes, and those are the arterial baroreceptor reflexes. There are two of them. Aortic arch and carotid sinus. They work pretty much the same, okay? And then this one is different, so I need you to listen and switch gears in your head for just a second. These are called the right atrial baroreceptor reflexes, and these are back end baroreceptor reflexes. Okay, so in addition to monitoring pressure in your arteries, you can also monitor pressure in your venous system. Does it make sense to you that the right atrium is at the back end? Do you see what I mean? Back end of systemic circulation? Okay. So there are baroreceptors in your right atrium and your superior and inferior vena cava. You with me? Okay. Now, those are way lower pressure all the time. They're never going to get up to arterial pressures, but they can get higher than they normally are. Yeah? So what would happen in those is they will respond to high pressure in the right atrium and the superior and inferior vena cava. They're going to still tell the medulla oblongata because that's what you tell, right? The sensory input's going to go to the medulla oblongata. But how is the medulla oblongata going to respond? What do you guys think? If you tell the medulla oblongata that I've got boatloads of blood in my right atrium and my superior and inferior vena cava, should it activate the sympathetic nervous system or the parasympathetic nervous system? Does everybody think sympathetic? It is sympathetic, because if you activated the parasympathetic nervous system, you would lead to congestive heart failure, wouldn't you? Because you'd basically say, slow down the output even though we've got major input, right? So what we need to do is, I've got a traffic jam, get the hell to work, right? So what happens is, with the right atrial baroreceptor reflex, it sends a high pressure input to the medulla oblongata, and the medulla oblongata says, hey, I know what to do, get the hell to work, ventricles. And then the ventricles get to work. Does that make sense? So it activates the sympathetic nervous system, makes it beat harder, stronger strength of contraction, stroke volume, right? And then you get more blood out. Is that okay? Now, the issue with these two is that atrial and arterial are spelled very similarly. Yes, I will spell them correctly. I will probably even put them in bold, but you have to read them, because don't you respond to high pressure entirely differently if it's an arterial baroreceptor than if it's an atrial one? Yes, you do. Okay, so I'll probably do everything I can, but you have to actually answer the question I ask, right? Okay. Oh wait. So that's the right atrial reflex, and basically what that one's doing is making sure that output keeps up with input. Yes, that's what that one is doing. Okay. Now the last one, and this one should make sense to you too. It's not super confusing. It's doing almost the same thing, only it's monitoring something different. This time what we're going to do is we're going to monitor the chemical content of arterial blood. Okay. And we're going to monitor oxygen, carbon dioxide, and pH. Do you remember that there's a relationship between carbon dioxide and pH? I think you've learned it before. Okay, so we're going to monitor those, and we're going to monitor them in the same places. Only these are chemoreceptors, not baroreceptors, but they're in the same places, still in the aortic arch and the carotid sinus. They behave the same. This one's more pissy, right? Okay, they do the same thing. This one's like easier to turn on. So here's what's going to happen. You guys predict, and then we'll see if you're right. If you detected in the aortic arch or the carotid sinus low oxygen, high carbon dioxide, or low pH, you would tell the medulla oblongata via sensory information, yes? And then the medulla oblongata should respond by activating which? Sympathetic or parasympathetic nervous system? High CO2, low oxygen, low pH. Sympathetic. Does that make sense to you guys? Okay. It basically means that you need better blood flow, right? Okay, so let's see if you're right.
Chemoreceptors in the carotid and aortic bodies monitor blood oxygen, carbon dioxide, and pH. Impulses from these chemoreceptors are conducted to the control centers for heart and blood vessels via the glossopharyngeal and vagus nerves. Chemoreceptors in the medulla oblongata monitor blood carbon dioxide and pH. Decreased blood oxygen, increased carbon dioxide, or decreased pH decrease parasympathetic stimulation of the heart, which increases the heart rate.
Decreased parasympathetic.
Decreased blood oxygen, increased carbon dioxide, and decreased pH increase sympathetic stimulation of the heart, which increases heart rate and stroke volume. Increased sympathetic.
What are you going to do to your vessels? Constrict. Got it. Yes.
Sympathetic stimulation of blood vessels increases vasoconstriction.
Got it? Does that make sense? Okay. So it's logical enough, isn't it? So here it goes. Now we have just done autonomic nervous system. In addition to tigers and anxiety attacks, how can you turn these damn things on and off? Chemoreceptor reflexes and baroreceptor reflexes. Yes? Should I put tigers on here in the future? Probably should put tigers on there in the future. Okay, everybody good? Okay.
So was that saying there was a parasympathetic and a sympathetic response?
Oh, well, you always...
Sorry.
Go ahead.
To the level of the chemicals in the blood.
Oh, yeah, you're always going to turn one up and one down, right? Remember that the parasympathetic is almost always on anyway, right? So you're going to have to do something to the parasympathetic the vast majority of the time, even if you were just trying to get at the sympathetic, right? Okay, so the parasympathetic is almost always doing something with your heart, unless there's a freaking tiger in the room and you just turned it off. What?
Is there a complete stop of the sympathetic nervous system?
Well, there's never a complete stop of the sympathetic nervous system everywhere, because the sympathetic nervous system maintains the tone in your vessels.
Okay, so there's some degree.
There's some degree of sympathetic stimulation going out, not necessarily to your heart, but always going out. Yeah. So, for instance, FYI, just because it was, a good curious question, if I damaged this region in my spinal cord, sometimes it's counterintuitive, but you can die by damaging that region of your spinal cord because it maintains your vessel tone. And if all of your vessels dilate simultaneously, your blood pressure will drop and you can die because of the nerve damage, even to the thoracic region in your spinal cord. I mean, everybody knows if you damage like above C3, you're probably going to croak. But why could you croak from thoracic spinal cord damage if somebody didn't get to you as quickly as they could? Because you just did massive vasodilation. You lost your sympathetic stimulation. Does that make sense? Okay. All right. So you guys all right with that? Okay, so what we just did is all of the nervous system ways to control heart rate, right? And now we'll just add some hormonal ways to control heart rate. And the hormonal ways to control heart rate are not all in here, because I just got tired of this being super complicated. But please note that hormonal control is here. You can add all the hormones if you want to. Oh, by the way, if you get to the point that you find this useful and not just super annoying, you can, instead of just having a PDF, which you can print out as big as you want, if you email me, I can send you the actual editable document. It uses a program called MindNode, and MindNode is available for all Apple products. I don't know if they have PC yet. So it works on your phone. It works on iPads. And they have a free version too. And the free version, you can edit this as much as you want. You can add details, you can fix it, whatever you want. You can use it for other stuff too. I just made this for myself because I like kept making paper concept maps of it over and over again. I was like, I do not want to make another paper concept map. I want to make one and then just fix it. Okay, so hormonal control is right here. So let's just look at the hormones. But you already know most of them, so this part isn't hard. So hormonal control of blood pressure. Epi is a hormone, yes, comes from the adrenal medulla. What does it do? Well, you already know what it does. It increases cardiac output, yes, stroke volume, heart rate. And what does it do to your vessels? Vasoconstriction. What's the impact, high or low blood pressure? Higher, yes? Okay. You may not know these. If you are uncomfortable with hormones, don't worry. Before your next test, we will go all the way through the endocrine system. So this is your first initiation to your hormones, but not your last, okay? So ADH is a hormone, antidiuretic hormone, and it's kind of telling you what it's doing, so just listen to the name. Antidiuretic is pretty much implying one of the targets, isn't it? What do you think one of the targets is? The kidney, okay? Comes from the posterior pituitary, goes to the kidney, and it has an antidiuretic effect. So it makes you retain water at your kidney, right? And then, guys, it's going to impact the vessels too, but instead of looking, tell me what would be consistent to do at the vessels with what you just did at the kidney. No, you are an antidiuretic. Antidiuretic will cause you to retain fluid and do what to your blood pressure? Increase. Now do something consistent with your vessels. Constrict. Yes. Got it? Okay. So the reason I said this is because if you remember one, you can figure out the other one, right? Okay. So the impact right here is to do what to your blood pressure? Increase. Got it? Okay. Angiotensin 2, we're going to talk about in more detail in just a second. It kind of comes from the kidney, but only kind of. And it's the most powerful vasoconstrictor in the body, which means it'll do what to your blood pressure? Increase. It also causes the release of this next hormone, which is aldosterone. Aldosterone comes from the adrenal cortex, and it causes you to retain water and sodium, which will do what to your blood pressure? Increase. Okay. Erythropoietin, you may have learned about in anatomy. EPO comes from the kidney, and it causes you to make more red blood cells and dumps them into your bloodstream, which would do what to your blood pressure? Increase. Got it. So please note how many things there are to increase the blood pressure. And this poor lonely one at the bottom is the only one that decreases blood pressure. Because remember, when we are serving the god of blood flow, yes? Yes, blood pressure was one of the primary determinants. So there's a jillion ways to increase blood pressure. Not very many ways to decrease blood pressure. So this one you already learned, but let's just go ahead and fill it in. ANP or ANF comes from the heart, and it causes vasodilation, and it also causes you to pee out more fluid. And those are consistent with each other, right? If it has a diuretic effect, what would it do to the vessels that's consistent? Vasodilation, and that decreases blood pressure. Got it? Okay, so these are the hormones. Now, please note that hormones manipulate blood pressure in the same way that anything manipulates blood pressure. They can hit the pump, they can hit the vessels, they can hit the fluid, and they will never contradict what they did with one at the other. Does that make sense? Okay, so alcohol. How does alcohol act on this system? Do you know what alcohol, small amounts, I'm not talking about going and getting schnockered or being an alcoholic. I'm talking about a couple glasses of wine, okay? But I'm just talking the direct impact that we have right here. It does have a GABA effect, and that's the CNS effect. But anybody have any idea what small quantities of alcohol does to your blood pressure? It decreases it, and it decreases it by mechanisms that should make sense to you. First off, it is a vasodilator, yeah, which does what to your blood pressure? Drops it. And it also inhibits the release of an antidiuretic, which makes it a diuretic. Yeah? So that drops your blood pressure as well. Does that make sense? It's an antidiuretic. It inhibits the release of ADH. ADH causes you to retain water, inhibits the release of ADH, and then you pee. Yeah, you can dehydrate. Yeah, on alcohol. Now, large quantities of alcohol will have exactly the opposite effect on your cardiovascular system as small quantities of alcohol. I know it's unpopular to say here, but with people who drink small quantities are actually have healthier cardiovascular systems than teetotalers, than people who don't drink at all, and way healthier than people who drink too much. So way healthier, yeah? Okay, believe it or not, did I tell you guys that like when I was having tons of heart problems, my super Mormon cardiologist told me that I can put you on this medication for 3 months, or I can prescribe you 2 glasses of wine per night. I was like, well, I was already going to do the second one. So let's just go with that. And then I got to tell my mother-in-law, who was shocked. She's like, he said what? I don't believe that. And I was like, he wrote it down on the pad. Okay. So last thing that we will do, no, almost the last thing that we will do today is, okay, so the last way to control blood pressure, guys, on the last part of our picture is, Charles, tell me one more time, 3 ways to control blood pressure.
Pump, tubes, fluid.
Tubes, fluid. Okay, we already did the pump, yeah? And we already did the tubes, yes? We talked about the resistance in the tubes, yes? What we have to do is the fluid, which involves what organ? Kidneys, yeah, so let's talk about your kidneys, okay? So your kidneys have the capacity to control your blood pressure by 3 hormones that we just barely talked about. Yes, we just barely talked about EPO coming from the kidneys. Yes, okay, and ANP or ANF going to the kidneys. Yes, and ADH going to the kidneys. That makes sense? Okay. Yes, we just talked about those. Those are all kidney related, either coming from or going to the kidneys. Erythropoietin, yeah, erythropoietin. And then what the renin-angiotensin system is what we are going to talk about now. So the renin-angiotensin system, we kind of implied it, and it's the one that we were talking about right here, angiotensin 2. But I have to tell you the whole story or it's not going to make sense. Ready? Okay. So the renal controls of blood pressure, they're way slower than heart control of blood pressure or vessel control of blood pressure. Because let's say I'm sitting here and my blood pressure is too low. My heart can help me pretty quickly and my vessels can constrict pretty quickly. But how quickly am I going to be able to retain enough fluid to increase my blood pressure? That's a longer term thing, right? So they're not like instantaneous control of blood pressure, but they're longer term control of blood pressure. And primarily what they're doing, guys, is just controlling how much you pee out of your blood plasma, right? Everything that comes out of your pee came from your blood plasma. So you can hold on to it or you can get rid of it, right? So that's the direct way that they control your blood pressure. But the indirect way that they control your blood pressure is this system that we're just about to draw. Okay. So basically what is going to happen is there's this little feedback loop. It's kind of cool. I mean, students hate it, but that doesn't mean it's not cool. They don't hate it as much as they hate signal transduction mechanisms. You ready? Okay, so here's what's happened. It's called the renin-angiotensin-aldosterone system. Here's what it does. You detect low blood pressure at the kidneys, okay? There's special cells, I'll tell you their name later. By the way, this isn't just something you'll use once. We will learn this system here. We'll learn it again in the urinary system and again in the endocrine system. So it'll be a good thing to get out of the way early if you can, okay? The renin-angiotensin-aldosterone system responds to low blood pressure at the kidney. Anybody tell me why kidneys might be especially sensitive to pressure changes? Because what do they do? That's pressure-based filtration, yeah. So they're especially sensitive to pressure changes. So if you detect low blood pressure at the kidneys will release an enzyme called renin. Doesn't really do a damn thing until it interacts with something that's already in the blood plasma. You ready? Okay. It will interact with something that is already in the blood plasma but not doing a damn thing either. Okay. And this is called, ready for this word that you're going to love?
No.
Angio, which means what? Vessels, tensin, which implies pressure, ogen, as in the genesis of. This was made by the liver. This was made by the kidneys. Okay, so I don't know how the hell the liver came into this. Just wait until you see what other organ is randomly associated with this. Okay, you ready? Okay. Angiotensinogen, it doesn't do a damn thing ever. It's just in the blood plasma unless it interacts with renin. You ready? And then when renin interacts with angiotensinogen, it forms angiotensin. Oh, gen, like the genesis of, okay, angiotensin. Angiotensin doesn't do a damn thing either until it interacts with an enzyme called ACE, right here, which is always present as well. Okay, this, of all places, comes from the lungs. What the what? I don't know.
I tap out.
Okay, so just stick with me. Almost done, I swear. It's not that bad. Okay, angiotensin, it was angiotensin 1. Angiotensin 1 gets converted by ACE. ACE is angiotensin converting enzyme. That's what it stands for. Okay? To angiotensin 2. Okay? Angiotensin 2 will take care of the problem because angiotensin 2 is a major vasoconstrictor and causes release of aldosterone. Aldosterone was a what? Diuretic or antidiuretic? Antidiuretic, yeah. Holds on to fluids. Okay, so I'm finished with the story. I'm just going to point out a couple things for you. What are these going to do to your blood pressure? They are going to increase your blood pressure. And when they increase it enough, the whole thing shuts off. It's a negative feedback inhibition loop. Yeah? Do you love it? Is it your favorite? Okay. Okay, so let me just point out a couple of things. 2 of these proteins are always around. Which ones? Angiotensinogen, which won't have a damn thing to do with ACE ever, unless renin gets involved. Okay, so let me just show you one last little thing, and that is, look back here. Do you see why when I said angiotensin 2 comes from the kidney, I put an asterisk? Because where does angiotensin 2 come from? I don't know.
Everywhere.
Kidneys, liver, and lungs.
Comes from the spleen, too.
But it's a hormone, isn't it? Because it like gets dumped into the bloodstream and has effects on like vessels everywhere. But it's a hormone with like 3 parents, right? It's one of the modern hormones. Got it? Okay. So that is the renin-angiotensin aldosterone system. So I'm going to take the last 2 minutes and tell you about spring break. And then, okay, so I'm going to write a long, difficult cardiovascular system take-home quiz for you. Okay? It's one that you have to rummage through your notes and pull out the thing and try to figure out all freaking different relationships, right? But remember, the quizzes aren't worth very much, so just try your best, and if you can't get it, like go back and look it up, and eventually, when I close the quiz, all of the answers will pop up anyway, right? Okay, so that's going to happen, but in addition, the wise physiology student would also come back after spring break with that endocrine table done. And so the endocrine table is all already posted for you. What I'm going to post for you is a short, like 10-minute video of how to fill it out, right? Where you get the answers and all of that kind of stuff. If you come back with it filled out, the endocrine system will be pretty comfortable for you. If you come back with it not filled out, you will feel completely overwhelmed, and then your test will be right when we finish the endocrine system. Does that make sense? Cardiovascular and endocrine. So I'm saying don't leave this stuff for the last minute or else you will hate your decision-making skills. You don't have any time for study. The semester's going to be like over in a second. This is not okay. That's how Charles feels about today.
4 hours of sleep,